Kia ora koutou katoa. Thanks for coming to today's update at the Ministry of Health. I'm Michael Dreyer, I'm the Ministry's Chief Technology Officer. Today I'll be giving you an update on the new IT systems that have been developed and rolled out specifically for our Omicron response. I'm joined remotely by Dr. McElnay, who's the Ministry's Director of Public Health, and she will start today's briefing with an update on today's COVID-19 numbers. Over to you, Caroline.
Thanks, Michael, and kia ora koutou katoa. Apologies that I can't be with you in person. I'm zooming in from sunny Napier. Today, I'm going to give you an update on the case numbers, hospitalisation numbers, and also just outline some recent research from Otago University. So firstly, today we are reporting 23,894 new cases across the country, with 9,881 of those in Auckland, and we'll have further breakdowns of those figures in our 1 p.m. statement. Aucklanders yesterday recorded their highest number of rapid antigen test results ever, 43,735. That's 25% higher than the previous highest day, which was last Monday. So a big thank you to everyone that's been putting their results into My COVID record. You will be aware of commentators like Auckland University's Rod Jackson, who says, whilst we're tracking the daily case numbers, they are only a minimum given the uncertainty that there is around reporting of results, and the actual number of cases in the community is likely to be considerably higher. That's one of the reasons why we're focusing on our hospitalisation numbers. And today there are 756 people with COVID-19 in hospital today. 16 of those are in ICU or a high dependency ward. The largest proportion of cases in hospital continues to be in the 3 Auckland Metropolitan District Health Boards. Information provided by those DHBs today is that case hospitalised numbers in Auckland are around the same as yesterday. In Waitemata, they're slightly up, and in Counties Manukau, they're slightly down. The actual numbers we can provide for you in the statement. Now, the ICU numbers are similar to yesterday. The DHB's report continued pressure on staffing, particularly providing cover through the night. Though today, I'm pleased to report that the DHB say they are managing and that occupancy levels remain manageable. People will be concerned about the number of people in hospital, and unfortunately, we do know that this number will grow. However, when compared to the Delta outbreak, the people being seen in hospital with Omicron have less severe illness. The lesser severity is strongly related to New Zealand's high vaccination rate, and many experts rightly warn that the illness can be very severe for those who are unvaccinated. While still early in our Omicron outbreak, our figures show that based on the data available, unvaccinated people are 4 times overrepresented in the current hospitalisation data. Just 3% of eligible people aged 12 and over in New Zealand have had no doses of the vaccine. However, of the eligible people hospitalised since community transmission of Omicron was detected, 17% have had no doses of the vaccine. During last year's Delta outbreak, the highest number of cases in ICU at one time was 11. That was reported on the 10th of November when there were 81 cases in hospital. Of those, 13.6% were in ICU, whereas for comparison with this outbreak, on Sunday the 6th of March, there were 618 cases in hospital with 10 in ICU, just 1.6%, so a much lower proportion of cases being admitted to ICU. Now, as you're all aware, isolating infectious cases has been a key strategy for preventing the spread of COVID. However, as our case numbers increase, our health services are stretched trying to operate services with large numbers of staff members being required to self-isolate. One measure that's been put in place to address this is an arrangement which now allows critical healthcare workers with COVID to return to work earlier than usual if their absence would mean that a critical health service would have to stop functioning. Now, this can only occur if the case meets strict criteria and all steps are taken to protect the safety and well-being of the case themselves, their patients, and other staff. The staff members' well-being will be checked daily, and if they develop symptoms or their symptoms worsen, they would stand down from work. There are 2 pathways currently available for critical healthcare workers who are cases to return to work. The first pathway allows healthcare workers with 2 negative RATs to return to work on day 6 after they've had their negative RATs. And the second allows COVID positive staff to return to work on wards where all the patients are also COVID positive without any stand-down period. Now, this second pathway can only be used if all other options have been exhausted, but it's an extra tool that enables our health system to keep running and keep functioning. Whilst at work, the healthcare worker must use a well-fitted N95 medical mask, follow infection control procedures, take care in any shared break or eating areas, avoid public transport where possible, and follow our standard advice for community cases outside of work. Before they can return to work, there's a number of conditions that those healthcare workers need to have met. They need to be fully vaccinated and boosted, be asymptomatic or have mild symptoms. They must agree to return. Staff should not feel pressured to return to work. They must work in a situation where their absence actually puts an essential service at risk. And as I've said before, they can return to work on day 6 if they've had those 2 negative tests. But we're very mindful of the very special situations for staff who may have to return to work at day 0 and the support that's in place to allow that. In that situation, though, they will only be working with COVID-19 patients. This approach is a pragmatic one to help ensure we continue to have staff available to treat individuals with COVID, but it also balances the significant risk to patients from hospital services not being able to operate against the small risk to patients from staff who have COVID in light of all the protections in place. And we can provide the details of those criteria further to you. And lastly, I'd just like to say a big thank you to the health staff across the Motu for being flexible, and we're seeing this all across the country, but particularly in Auckland because of the bulk of cases, how flexible staff are being and working together to keep our health system running. And just a bit about the Otago University research. You may already have seen a recent analysis by Dr. Jennifer Summers, Professor Michael Baker and Professor Nick Wilson of Otago University's Public Health Department. They've just released an analysis of excess winter mortality, and they found that New Zealand's COVID-19 response had saved 2,750 lives from excess winter mortality. That's a common public health way of comparing the number of deaths during winter compared with those in a non-winter period. And while we've known for some time that personal hygiene, social distancing and lockdowns have suppressed all other respiratory viruses, this is the first time that we've seen that impact across the board being measured. Separately, the researchers also used our world and data figures to calculate New Zealand's mortality experience compared to various other countries on a per capita basis over the first 2 years of the pandemic. And in summary, compared to overseas experiences, New Zealand has seen a very low number of deaths due to COVID. Whilst Omicron has seen proportionately fewer cases admitted into hospitals overseas, what we're seeing overseas is the sheer number of cases, meaning that hospitals abroad are likely to continue to come under pressure. For example, Germany last week reported its highest total number of daily cases at 161,040, followed by South Korea at 147,429. And because of the differences in testing reporting times, these figures are expected to be lower than the true number of infections. So finally, please remember that we can all play our part to slow the spread of the virus, to help protect our most vulnerable, and make sure our health system is able to cope with extra demand. Please keep doing the basics well. Wear a mask to protect yourself and others. Physically distance. Practice good hand hygiene. And please get tested if you develop symptoms. Stay home if you're unwell. And we encourage everyone to continue to promptly report their test results. I'll now hand back to Michael. Thank you.
Thanks, Caroline. So in recent weeks, the Ministry of Health has released a large amount of new technology to support the Omicron response. You can now self-report a RATS test online via My COVID Record. You can order a RAT via the same channel. You can record where you've been via new and improved tracing form to support contact tracing efforts, and visit a one-stop shop called the Health Hub to find information relevant to your situation. These systems were designed, developed and delivered tested and delivered at pace. However, with all new IT systems, there are initial bugs and process flows to sort out. So I wanted today to outline some of the improvements that have been made since they were first released. Like the rest of our COVID-19 response, we are constantly refining our systems, taking on board feedback from our health workers and our health consumers. The COVID clinical care module is technology which joins up health information about each case for our healthcare workers, so they can ensure those with COVID-19 they are caring for have access to the clinical care and welfare support that they might need. When the system first went live in mid-February, around 4,000 cases an hour could be processed through these systems. During busy mid-morning periods, we could see that this peak caused delays. Further capacity has now been built into this system over the past 2 weeks, which means it can now handle around 20,000 cases an hour, and we continue to work through and enhance these processes. The RATS requester site went live last week, and despite an initial intermittent bug, which was fixed within the first few hours, it is now fully operational and being used nationwide. Yesterday, 55,000 total orders were placed. All but 1,000 of these were through the web form rather than the call channel, and around 220,000 total test kits were ordered. Please remember to report your result on My COVID Record, even if it's negative. And please make sure everyone in your household has also submitted or reported theirs. Later this week, we will enable you to report a RATS result on behalf of someone else, perhaps in your family, or particularly for children under 12, via the My COVID Record tool. Don't forget there's also an 0800 number for this, if you prefer, or if you don't have internet access. You can also do this via your GP. The self-reporting of RATS helps provide a clearer picture of how the pandemic is progressing, both at a national and a regional level. It is essential we have as much information as possible to help inform public health decision making. We have also improved the online contact tracing form. After we heard from the public it was taking too long to fill out. With public health advice, we have streamlined it to focus on high-risk events or exposures and welfare needs. This has reduced the average time it takes to complete the form from 30 minutes down to 8 minutes. We also heard that people wanted a single source of information about what happens when they or someone else close to them gets COVID. So last month we launched the COVID-19 Health Hub. It's a simple, easy to navigate, one-stop shop with all this information. There is also plenty of this information available, as always, via the United Against COVID website. From the 10th of March, we will be going live with text messages that notify people that their isolation period is complete. And we're also considering reminders for those people that have ordered and received RATS tests but have not yet submitted a result one way or another. As with all of our systems, we have 0800 numbers for those who cannot access information online or simply wish to speak to someone for advice. Where possible, though, we do encourage to please use these online services. They are quick to use. I like to think they're easy. And they take pressure off our call centres and off our frontline staff. So we do appreciate the public's engagement with these already. It's great. So we'll now stop to take questions.
Can you, Dr. McElnay, tell us how many hospital staff are currently off work because they are infected with COVID-19?
I don't have the exact numbers. We will see if we can get those numbers for you, but I don't have those to hand.
Is that a figure that the Ministry of Health collates? A colleague of mine has been trying to get it through DHBs and hasn't had much luck, but it seems like a pretty critical figure to have.
I'm not sure that the Ministry of Health collects those numbers because the management of the absenteeism and illness among staff is managed at the DHB level. So the DHB will have those figures, and they are the ones who are then, managing and balancing staffing issues to be able to move staff around within the DHB to make sure that the services are running, or adjusting some of the running services to free up people in other places. I'm aware of quite a bit of movement of some staff, doing alternative duties in order to cover the essential areas. So the DHBs will have those figures. I'm not aware that we at the Ministry collect those, but we can look into that for you. But certainly at a DHB level, it should be available.
Dr. McElnay, are you able to explain, please, how the Queenstown vaccine temperature botch-up was able to happen?
Thank you. Yes, I've spoken to some of the staff in Southern District Health Board, and I don't know the details of what actually happened there, but I am aware that this was a cold chain issue that came to light, and cold chain is one of the critical areas for all vaccine distribution. It's something that we've had systems in place for any vaccination provider, regardless of the vaccine, to make sure that the cold chain is maintained throughout its whole distribution, right up until it's arrived at the health provider and then given to the individual. So I've been advised that the DHB is obviously managing that situation, and that they will be doing an investigation into, or an event review into what exactly happened in this situation. I don't have those details at this moment.
Yeah, given the fact that there was a number of frontline workers that have been affected by this, they haven't been fully protected. Is that good enough from your perspective?
I think it's very unfortunate that this has happened, and we really apologise to those individuals who went along to get vaccinated and then find that because of this issue that their vaccine may not have been as effective as they thought it was going to be. I am aware that all of those people who were affected by the issue in Southern have received a letter from the DHB with individualised details about what they need to do so that they can go and get revaccinated. And just want to reiterate that our apologies and our sympathies for people concerned with this.
Dr. McElnay, what public health advice was considered when making the decision to send COVID positive workers back to work?
So we did a very thorough review of the likely risks and benefits for enabling this to occur. As you're all aware, there is pressure with the large number of cases and household contacts that we're seeing at the moment, but amongst our healthcare staff, but particularly for cases who are well. And there are some very specialised areas where it can be quite challenging to continue to operate those services. So we looked at how this could be enabled in a very safe way. We're very mindful of the health and safety of the staff member, as well as the health and safety of their co-workers and clearly their patients. As I said in my initial talking points, there are two different paths. The first path is where the case is at day 5, that if they're well, they'll have been off work, they have to stand down for those 5 days, but they do a RAT test. If that's negative, they do a repeat RAT test the next day, and if that's negative, then they can go back to work. So we've got a high degree of confidence that those workers are no longer infectious because of those 2 negative RAT tests at near the end of their isolation period. What we have said for the other pathway is that that is something that should only be used in extreme circumstances, and I'm not aware that it is actually being used at the moment, but we put it in place in case it is necessary for some of the highly specialised services that we know do operate in Auckland. And that's a situation where the case would be asymptomatic, so no symptoms, or even just very mildly symptomatic. It allows for them to return to work from their day 0 from their first positive RAT test, but with very strict criteria around when they can work. And of course, they can only work then in COVID wards. So those are working in places where there are people who've already been exposed to COVID. There are already cases of COVID. And so the risk that the healthcare worker poses to them, actually there isn't a risk from a COVID point of view. So we've been very thorough to make sure that we are minimising the risk at all levels with putting forward that or enabling that approach.
Dr. McElnay, with the Chatham Islands cases, what links have been established with the mainland, for example? What any links have been established between those cases and the Wellington protest group? I'm
not aware of any links with Wellington protest group, the health services for the Chathams are provided by Canterbury District Health Board, and they are looking after those two individuals. But that's all that I am aware of at this stage.
Going back to this new system, when did you make this decision? Was it always the plan to implement this system, or is it simply because you're facing chronic shortages?
Sorry, was that the question back to the healthcare worker issue?
Yes, back to this new system.
Yes, so we've previously had a system in place that would allow healthcare workers in some situations to be able to return to work. So certainly that had been envisaged, but that was this situation where healthcare workers could go back early. So that's with a negative RAT at day 5 and day 6. So essentially for those healthcare workers shortening their period of isolation, but only to allow them to go to work. So that had always been something that we knew that we would probably need to be able to implement. And then we were specifically asked to provide advice and a pathway for the situation where you may have a lot of COVID cases on a ward, and you've got staff that you need to care for them, and that those staff are well but have tested positive for COVID. And so we knew that it was likely to be needed, but in terms of when it was implemented, it was last week, end of last week, that it was implemented, and we were able to advise our health services over the weekend that that was now a pathway that was available for them.
Do you know how many staff may take up this option to come back to work? And I guess what protections have been put in place to ensure that they don't spread COVID to other staff and patients who don't have COVID?
I don't have the numbers, and it may be that that's why we put it in place as to enable, and we will ask the district health boards how many staff they are actually using on that pathway. I'm not aware of any staff currently using the pathway which allows them to go back to work immediately, but only in a COVID ward. But we can check on the details for you. In both situations, we put a lot of wraparound in terms of use of PPE, the staff being vaccinated, advice about how they interact with their co-workers during staff and meal breaks. And so we put a lot of guidance around that. There's quite a lengthy guidance document that's been developed with DHBs, so that staff at all times we're minimising any risk to others from those staff.
And do you know how many patients have missed out on planned operations because of the Omicron outbreak?
Sorry, I don't have a number available for you. Most of our health services are reporting that they are continuing to be able to keep business going as much as possible. It's primarily in Auckland. Some of the hospitals there have had to do some reduction in health services. I'm not aware of how many patients have actually been affected, but again, we can get those figures and come back to you with them.
Of the current cases, what percentage are believed to be Delta and what percentage are thought to be Omicron?
Our assumption at the moment is that they're all Omicron, but that is an assumption because we did see at the beginning of the Omicron outbreak that there were still some Delta cases circulating. Our whole genome sequencing is the only way that we can really distinguish between the Delta and the Omicron. And at the moment, because of the sheer number of cases, we're not able to whole genome sequence all of those cases. So there's a prioritization process in place for that whole genome sequencing that is very much focused on our hospitalized cases. The last report that I saw suggested that what we're seeing is predominantly Omicron.
How many cases are subject to whole genome sequencing, and what, when you say predominantly, what percentage roughly?
We can get you the actual percentage from the last report from ESR, but they report to us frequently on the whole genome sequencing. They certainly were saying that Delta, they were seeing the occasional Delta, but it's actually been some days since they'd seen the last case that was whole genome sequenced as Delta, and we'll just get the date of that for you. I just want to caution that because we're not whole genome sequencing all of our cases, we actually cannot say whether there's potentially still some Delta out there, but our assumption, and the most recent whole genome sequencing, I understand, has confirmed that it's Omicron that we're seeing. Our assumption is that this outbreak is primarily Omicron, but there may still be a few Delta in the community that we haven't been able to pick up and whole genome sequence.
How many cases are being whole genome sequenced? Thousands, hundreds, dozens?
It will be in the hundreds. We've had to prioritise the samples that are referred to ESR, and so the primary focus at the moment is hospitalised cases. So it's in the hundreds.
Dr. McElnay, MedSafe has just approved Paxlovid, but it's not going to arrive here until at least April after the Omicron spike. How likely is it that we'll be able to speed up that delivery?
I'm not aware of any particular issues there with that delivery. Obviously, we will always try to do what we can to increase or speed up delivery if it's about distribution issues. We can take that away and look into to see if there's any particular issue that we can speed up.
We've got some pretty strong capabilities around distribution that we developed during the vaccine program, and obviously more recently for rats tests.
Dr. McElnay, there's still only 11 approved rapid antigen test types in New Zealand. Australia's approved more than 30. How satisfied are you with that situation, with us lagging so far behind Australian approved numbers?
Well, we have a process in place for approval of the rapid antigen tests. My understanding is that our approval process has been recently reviewed to look at the criteria for approvals. That we, on the basis of that review, the ministry has gone back to a number of rapid antigen test distributors and asked them to submit more information, which I understand we're waiting for that information to be received. And if that information is acceptable, then likely that we will be approving more. I mean, we have a system and a process in place to make sure that the rat tests do what they say on the packet, literally. And so we're just very, very mindful that since we're relying so much on our rat tests at the moment, we do need to make sure that we've got as accurate a test as possible. So I'm confident that we will see an increase in the number of rat tests that we approve going forward. You have to bear in mind that we do have different systems and processes from Australia.
Why are our systems and processes so much slower than Australia's then? And why are products that have been approved in Australia and have high
I'm not sure.
It's been approved, not been approved
Sorry.
here?
I'm sorry, could you repeat that last bit?
Why are our systems and processes so much slower than Australia's, and why is it that products already approved in Australia, which has standards comparable to or higher than our standards, not been approved yet? Yeah.
I don't think it's an issue of us having slower processes, it's just that our processes are different, and so that does mean that even though something is approved in Australia, that doesn't mean that it's automatically approved in New Zealand. That applies to a wide range of medicines. That's not just specific to rat tests. So this is something that New Zealand has. We have our own processes and our own criteria, and manufacturers have to meet our criteria in order to be approved. So that's what we're working through, and I'm hopeful and confident that yes, we will see some more rat tests approved once the manufacturers have completed their process, which is to provide us with the information that we asked for.
Can I just go back again to this new system? What considerations have been made for the health workers that have to go back to work, given that stress, for example, is a factor in long COVID?
We've been very clear in our guidance that staff should not feel pressurised to go back to work at all. And the Auckland District Health Boards have been discussing with staff unions to make sure that this is understood, that this is the case, that staff should not feel pressurised to go back. And we've also requested that there is a daily staff check-in, which is not just about COVID, but is actually about their overall well-being. And if at any moment, any point in time, staff do feel stressed or concerned that they're back at work, then our recommendation back to the DHBs is that those staff should be stood down and that the DHBs look at alternative ways of staffing those facilities.
Also, is there any particular reason you're in Napier today? Are you isolating?
I'm not isolating from COVID, but I do have some symptoms, and I'm following my own advice, which is if you're symptomatic, stay home. And Napier is my home, so I'm working from Napier.
Doctor, just in relation to the Nature journal finding that possibly even mild Omicron infection may be bad for brain, particularly smell and memory, have Ministry of Health officials taken this new study into account yet, and will they do so when providing future health advice?
Sorry, was that question about long COVID? I missed the beginning of it.
It's about a Nature study of 700 to 800 participants, and they found significant deleterious long-term effects from the virus.
Yes, we are looking at the effects of the broader effects of COVID and the longer term effects of COVID. It is our Office of Chief Clinical Officers at the Ministry are heading up the work in that area. We have been actively looking at the evidence ever since COVID and the long-term effects of COVID we became aware of it. So that particular piece that you're referring to, I haven't read it myself, but I'm aware that our Chief Clinical Officers have, and we're also working with the University of Wellington to establish studies into what we're seeing in New Zealand in terms of long-term effects of COVID.
I will add there's some content changes coming on the Ministry website around long COVID in the coming days and weeks.
Question for Michael. You've mentioned a number of technological sort of improvements or changes. What capacity was there, I suppose, in the earlier part of the pandemic for this, or has this been something like quite a massive shift that the Ministry of Health has had to pivot in implementing these things?
Right. So I guess over the last couple of years we've built quite a broad ecosystem of technologies to cover COVID. Probably began with contact tracing, testing, isolation, quarantine, vaccine, and now care in the community. The care in the community piece, which is where we're looking to, I guess, better enable the health sector and welfare to support people isolating at home, does bring together a number of those technologies we've developed over the last couple of years. It does also bring into play some of, I guess, the older technologies in the health system, a little bit of a mix of the old and new. And there are a number of, I guess, there's integration between lots of the IT systems and data flows that don't always work in absolute real time. So that's I guess, a constant challenge or opportunity for us to make things happen in real time. But yeah, we continue working on that. Any other questions today for either Dr. McElnay or myself? Okay, well, thank you very much for coming along. I think we've got another media stand-up on Thursday, so we'll probably see some of you there. All right, thanks very much.
Thank you. Goodbye.
Thanks.